Record to the eye.
Got it. Hi guys, welcome back. So it's been 2 months. That was the first month I think we've taken off in like 2 years that we've been doing it. I blame Casey because I was working, but that's okay. Well, welcome back. So I am Dr. Leichliter. I'm a neurologist here at Allegheny Health Network. Most of you know me. If you don't, if you're new, welcome to the party. So I'm a movement disorder specialist. I specialize in Parkinson's disease, among other movement disorders. I'm glad to be back. General rules of thumb, and so kind of things that I always, kind of housekeeping rules that I always go over first is, this is not a great forum to get specific or individualized care. So, don't say, hey, I'm your patient, fix me, or don't say, hey, I'm on this medicine, what do you think we should do next? My answer is you should really talk to your neurologist. Communication with your neurologist, your neurology team is key. And also everything you hear on here is my opinion. So again, generally my opinion, I think, is based on as much medical fact and knowledge as is currently available. But a lot of times, as you guys know, there aren't a lot of medical facts or knowledge available. And so then I have to make it up. If I'm making stuff up, I'll usually tell you I'm making stuff up. I'll throw up some quotes saying it's all me. But again, my opinion may be very different from your neurologist's opinion, or another movement disorders specialist's opinion, or your neighbor's opinion, or your cousin's friend's nephew who once heard something on a recording's opinion. End of story. Without further ado, I did get a few questions sent to me in the email, and so I'll start with those ones. But as Casey said, if you come up with questions, type them in the chat box. I'll go through that and kind of read through those as they show up, and we'll see what we can accomplish for the next hour. I really enjoyed the first question that I got. So the first question that I got was, why are we still suffering with Parkinson's? And why have we received $0 out of the government's bounty? I was entertained by that question for whoever sent that one in. I don't know why the government doesn't put more money into Parkinson's disease, in all honesty. Now, the Michael J. Fox Foundation has put a tremendous amount of money into Parkinson's disease. And you can look at that one of two ways. You could look at that and say, hey, look how good we're doing moving research forward. I think on their website now they said they've raised about $1 billion for Parkinson's disease research, which is a tremendous feat. I guess when you're Michael J. Fox and famous people, you can do stuff like that. And so on the one hand, I look at that and I say, that's great. Think of all the studies that we've funded, all the research that we've been able to do. And then the pessimistic side of me says, wow, we've put $1 billion into this and Cinemet's still the best we have. Again, you can view that however you want. But the first part of that question actually has in my opinion, a much more interesting answer. Why are we still suffering with Parkinson's disease? Why haven't we been able to fix it? And again, this is all my opinion. There's a lot of opinions out there. My opinion is similar to a lot of other people's, which is Parkinson's disease is not one thing. The problem with Parkinson's disease is it's a lot of things. So there's a lot of genetics behind Parkinson's disease. There's a lot of triggers behind Parkinson's disease. There's a lot of things that add up, all the Swiss cheese holes that have to line up for you to develop Parkinson's disease. And so you may have one version, but person over here has a completely different cause or a completely different reason for their Parkinson's disease. Parkinson's disease is based on symptoms, so we don't really have a great test for it. So everybody who comes to my office with resting tremor and slowness of movement and cogwheel rigidity and balance problems gets labeled as Parkinson's disease, or at least Parkinsonism. And then if you have typical presentation, typical onset, typical progression, typical response to Cinemet, I call you Parkinson's disease. The problem with diagnosing people based on symptoms and based on clinical findings is it does nothing to tell you anything about the underlying brain pathology. And just because the end result is tremors and stiffness and slowness and movement and balance problems, there's probably a whole lot of different ways to get to that end result, meaning there's a whole lot of genetic combinations, there's a whole lot of environmental triggers, there's a whole lot of steps in the process that all end up at the same result. And this is why I really don't think Parkinson's disease is a disease. It's more of a syndrome, which means it's really just a combination or constellation of symptoms. That's important because let's say you're doing a drug trial. So let's say I have a drug that fixes a certain variety of Parkinson's disease. Let's say I had a cure for that. Well, I'm gonna do a drug trials, and I'm gonna spend my $1 billion to do my drug trials. And at the end of the day, we're gonna test it in Parkinson's disease. Now, the problem is I have no way to genetically identify or, genomically identify people's type of Parkinson's disease outside of physical exam and really history and physical. And so I'm going to enroll in that drug trial of this cure for a certain small subset of a specific type of Parkinson's disease, everybody who has Parkinson's disease. And even if it fixed, let's say it fixed 1 out of 20 or 1 out of 100, that drug trial is going to fail, right? Because the other 99 out of 100 or the other 19 out of 20 are not going to have that specific form of Parkinson's disease. They're not going to respond to my cure. It's not going to work. That's a very long way to say we really need a better way to get to the pathological diagnosis or a marker or some sort of black and white answer that we can then test subsets of patients with either different medications or combination of medications before I think we can really start getting to the fixing part. I really do think we need markers. We need measurable tools before we can even think of fixes, disease modifying medications, cures, things like that. And so now they're working on this, don't get me wrong. There's a whole panel of Michael J. Fox Foundation money that's spent on biomarker profiling and things like that. And so again, I'm optimistic that someday we are going to be able to do this. I just don't, and I can't tell you when that day is going to be. And unfortunately, I don't think it's today or tomorrow. I think this is going to take some time, but I foresee this being the order. We have to have some sort of marker or some sort of test, preferably a marker of disease progression, and then we can start tailoring the treatments to the people that have certain or specific markers. That's really, in my opinion, the only way to get to actually disease modification and cure. Nonetheless, I thought it was a really interesting question. I also like the next question, and this is like, Dr. Leichliter, we know your favorite thing to talk to. I'm going to stab you in the heart with this one. If exercise is supposed to be neuroprotective, then why would a person like myself who has been a lifelong exerciser get Parkinson's disease, right? This is not the first time I've been pressed with this question. It's like a dagger in my heart because exercise is my favorite thing to talk about and the only thing that I really harp on people on the most. And if you're my patient, everybody in this audience knows this. This is not a surprise to anybody. And I don't have a good answer for that question. The only thing I could think of is, or the only logical or rational explanation I can come up with is maybe you were going to get Parkinson's disease 5, 10, 15 years sooner than you did, and it was the exercise that actually delayed the onset of it. I have no evidence behind that. There's no way to prove that. There's not even, I mean, outside of logic, there really is I have nothing to back that up. Nothing. And there's been some studies that called into question the benefits of exercise. Is it really disease modifying? Does it really slow down disease onset or keep you better longer? And I personally think it does. Again, in my experience, exercise has been the one thing that overall helps people do the best. I always tell my patients that people fall into one of 3 groups. There's the people that come to me that, like this person, have been lifelong exercisers. They're gym rats. They show up in their gym clothes. They've been working out at the gym their whole life, whatever. Those people always do the best. So even if you ended up getting Parkinson's disease, and maybe it did delay the onset, those people still usually have a slower course, less symptoms, easier to treat with medicines. They still do the best. The second group of people are the people that after I yell at them a few times or after I harp on them and I nag them and I yell at them, They agree. They finally see the light at the end of my tunnel, and I say, and they start going to the gym or they start exercising. And then they come back and say, you know what? I feel better when I exercise, because everybody feels better when they exercise. I'm not going out on a limb on that one. And they do better. And then the last group of people are the ones that no matter how many times I talk to them, and no matter how many times I yell at them, and no matter how many times I harp on them, or their wife nags them, or their significant other yells at them, they don't do it. And it's not always out of lack of trying. A lot of times there's pain or back problems or knee problems, or fatigue is a big issue. Believe me, there's a lot of reasons why exercise is difficult. If it was easy, everybody would do it. And no matter how, for whatever reason, we just can't get them to exercise or get them up and moving. And those patients always do the worst. And I've seen this just time and time and time again. Those three groups of people, you can always see what level they're at and how they do. And so the answer to the question is, I don't know. I don't know why a lifelong exerciser would get Parkinson's disease. I don't know why, Davis Finney would get Parkinson's disease. I don't know why, Roger Bannister, who was the first guy to run a mile in under 4 minutes, would get Parkinson's disease. I don't know. All I can think of is that exercise is still the best thing that I would suggest that you do. I still think it does indeed slow down disease progression or delay onset, although again, maybe that's iffy, and I still recommend it to everybody. That's about all I can tell you about that one. I thought those were good questions, though. Good job for whoever sent those ones in. The next one that I got was actually about a smartwatch. So it was an article from, I guess, The Guardian that suggested that the NHS smartwatch for Parkinson's patients hailed as life-changing. And I haven't actually seen it or gotten to look at it. I used to work with a company that had a kinesia. I can't remember the company name or the actual device name, but long story short, it was a watch-like device or a wrist wearable device that measured things. So I would get a report that would show me, it could measure on time, it can measure off time, it can measure tremors, it could buzz and give people a reminder to take their medicine. So I think it's similar to what this one was. And I think it was okay. I wouldn't call it life-changing by any means. That's a strong word to me. I would say it's helpful, but and I don't think, going out and getting one of these things is vital to everybody's success. What I do think this highlights is a lot of things. So one is, neurologists are hard to come by. In fact, as an aside, being in the medical field right now is very challenging. There's not a lot of help. There's not a lot of people. There's not enough of us. There's not a lot of nurses. There's not a lot of nurse practitioners, physicians, assistants, so on and so forth. And so communication is much more challenging now than it's ever been in the past. Getting people to answer the phone, getting people messages. If you're any of my patients are in the audience, you're all probably nodding, say, yeah, it's been really hard to get a hold of anybody these days. And I don't disagree with you. It's a tough time in the medical field these days. And then to push that a little bit further, it's really hard to get into me. So there's a lot of patients and not a lot of me, or not a lot of doctors or neurologists in general. And so you get about 20 minutes with me face to face every few months. That's not a lot of time. And so things like this are another way to get information to your neurologist, to your doctor, in between office visits, so we can kind of see how things are going in real time. Now, the hard part is it's a lot of data. These watch things collect a lot of data, and it's hard to sift through, and it's time consuming. And so it's not ideal from my standpoint. But it is a way to get in between visits information to us, knowing the current status of the medical field. The other thing I think it highlights is that, technology is coming. And what you're going to see in the future of medical care or medicine is more and more technology. You're going to see more wearable devices. You're going to see more smartphone devices. You're going to see more interfaces between computers and electronics and you and your doctor. Teleneurology, which we do now, is just the beginning. So just know that going in. Technology is going, for better or for worse, whether we like it or not, technology is going to be a, a part of the future of medicine. It's not going away, and you're only going to see more of it, whether we like it or not. And again, I think things like this wearable watch device, is just another example of technology. And we could fight it. David, I saw you give it a thumbs down. We could fight it. We could say, no, I'm not going to do that. I don't want to learn new things, but that's not going to work. At the end of the day, we have to figure out the best way to use technology to our advantage, because it does have some upsides. It's not all negatives, as some people would lead us to would think. And so I do think the appropriate use of technology for the right people is really going to help us take care of more people, particularly with the constraints on time, the limited number of doctors, neurologists, assistants, so on and so forth, and the difficulty with travel, the difficulty with parking in my garage, which I hear about 15 times a day. Believe me, it sucks. All of these things play a role in how we're going to use technology. And so, again, I do think that while I don't think that watch is life-changing, like the very brief article would lead you to believe, I do think it highlights a few things, and that's why I brought it up. What is cogwheel rigidity? Did I hear that right as a symptom of the syndrome? Yes. So cogwheel rigidity is a cardinal symptom of Parkinsonism and Parkinson's disease. And what that means is it's actually a combination of stiffness and tremors. So stiffness, and when I talk about rigidity or stiffness, this is not, hey, my back is stiff when I get up after sitting for a while, or my legs are stiff when I haven't moved. This is not a stiffness that patients can appreciate or feel. This is a stiffness that I can appreciate when I passively move your joints when you're at rest. So if you're my patient, every time you come in, I feel your arms and I bend you and I kind of bend your wrist and I bend your elbow and I tell you to relax. And then you tell me you can't relax. And I say, do your best. And sometimes I have you draw a figure 8 on the other side. And that's what I'm feeling for. And what it feels like is a catch. So it kind of goes catch, 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 a lot like a socket wrench or a ratchet is the best way to describe it. And what it is increased tone coming from the basal gang, the brain changes that we have, with superimposed tremor. The tremor is what gives you the ratcheting. And cogwheel rigidity is one of the 4 cardinal features of Parkinson's disease. That, along with the tremor, the slowness of movement, and the balance problems. And so, yes, cogwheel rigidity is something you will hear us refer to. And usually we feel it in the arms, but you can feel it in the legs. And it's that sensation of kind of ratcheting when we move your joints. So again, everybody says, oh, well, yeah, I'm stiff. When I get up, my back cracks and I can't move. That's a different kind of stiffness. This is stiffness that really your doctor is going to feel, or somebody else sitting next to you can feel, by passively moving your joints. Are there still only 2 movement disorder centers in Pittsburgh? Yeah. Yep. Unfortunately, and realistically, and again, part of this is insurance driven. Again, there's 2 major health systems in Pittsburgh, right? There's UPMC, there's Allegheny Health Network. How many doctors and how many patients? Not a lot of doctors and a whole bunch of patients is the short answer. So in my practice, there's really only 3, kind of 2.5 movement disorder specialists in Allegheny Health Network. So there's myself, there's Dr. Susan Baser, who trained me and taught me everything I know. And then there's Dr. Mary Flaherty down at Jefferson, who I helped train. She's only part-time down there. That's why I say 2.5. I'm not entirely sure how many UPMC has these days. I feel like their numbers fluctuate more than ours. But the short answer is, and David, you can correct me if I'm wrong, there's thousands of patients with Parkinson's disease in the Pittsburgh area, if I'm not mistaken. And so you do the math and you can tell just how hard it is to get in with us. And that's not even to say that Parkinson's disease is not the only thing I take care of. I take care of tremors in general. I take care of Huntington's disease. I take care of tics. And so again, the numbers really do add up. And so if you're wondering why it's so hard to get in to see somebody, or why it's so complicated and there's so much of a delay, it's because there's really not enough of us to take care of and handle all the patients that we have. There's probably a more, I don't know the number over at UPMC. I only know our numbers, but the short answer is they don't have enough people to cover all of these patients either. And that's why it is such a challenge. But yes, as far as I know, those are the only two places in Pittsburgh that have movement disorders specialists. What is the differential diagnosis between Parkinson's disease and Lewy body disease? What would be a good determining factor if someone has been misdiagnosed with Parkinson's versus Lewy body disease? I actually just answered this question earlier today. This is a very common question. And so I'm going to take a little bit of a step back and try to frame this a little bit differently and give you a more broad answer to it. So Parkinson's disease, Parkinsonism, and this is where it gets confusing, so bear with me for a minute. Parkinsonism is the umbrella term that encompasses everything that has the 4 cardinal features of Parkinson's: the stiffness, the tremors, the slowness of movement, the balance problem. If you have those cardinal features, you have Parkinsonism. If you liken this to dementia, it's kind of like the difference between dementia, which is the umbrella term, and Alzheimer's disease, which is the specific term. So Parkinsonism is the umbrella term. Parkinson's disease is the specific term. So for everybody who has Parkinsonism, if you have typical progression, typical onset, everything is typical and it follows the course that I think it should, and it responds to medicines the way that I think it should, I call it Parkinson's disease. If it doesn't follow any of those things, or if something's a bit odd, or you don't respond to medicine the way that I like or I think you should, or things are progressing too quickly, or there's some other weird symptoms that don't necessarily fit with typical Parkinson's disease, then you have more Parkinsonism. There are a subset of those people that have what's called a Parkinson's plus condition. Parkinson's plus conditions are pretty much exactly what they sound like. Initially, they look a lot like Parkinson's disease. They have tremors, they have stiffness, they have slowness of movement, they have balance problems. And then they start developing other symptoms, or the plus part of it. And Lewy body disease is one of the Parkinson's plus conditions. The other ones are progressive supranuclear palsy, multiple systems atrophy, and corticobasal syndrome, or corticobasal ganglionic degeneration, which sound like really long names, and they all mean something, none of which you really have to memorize or know. There's no test at the end of this study session. Lewy body disease is oftentimes very difficult to tell from Parkinson's disease. And the reason is they look very similar. And the main hallmark for Lewy body disease, and Lewy body disease is also called diffuse Lewy body disease, Lewy body dementia. This is all one thing that we're talking about. The hallmark of Lewy body disease is very prominent hallucinations, usually visual. Now, everybody here is going to say, but wait, you've talked about Parkinson's disease hallucinations not infrequently, and you're right. This is where the problem is. So Parkinson's disease can also have hallucinations. Lewy body disease also tends to have a lot of blood pressure fluctuations, and they tend to have ups and downs during the day. But wait, Parkinson's disease can also have those things. And so this is why it's so challenging. And there's no test that tells the difference between Lewy body disease and Parkinson's disease. The two things that tip me off or suggest Lewy body disease more so than Parkinson's disease are dementia. So early signs of memory problems, confusion, things like that. If you read the textbook, it says dementia usually comes within the first year or two of a diagnosis of Parkinson's disease, is more Lewy body disease. And very, very prominent hallucinations, particularly early in the course of disease, particularly on little medicine. The only people that I feel very confident in calling Lewy body disease, where I will actually write in the chart Lewy body disease, are people who are already hallucinating before I put them on medicines. And this gets down to really what the difference is. So the distinction is, in the hallucinations at least, is what causes them. So in Lewy body disease, the hallucinations are caused by the disease. The Lewy bodies that are diffusely spread out through the brain. And I'll come back to Lewy body in 1 minute. Bear with me. In Parkinson's disease, we think the hallucinations are coming from the medicines. And so once I put somebody on medicines and they start hallucinating, is it the medicines or is it the disease? So really the only people that I feel fairly confident about A relatively definitive diagnosis of Lewy body disease are people who are hallucinating before I put them on medicine. Then you know it's not the medicine, it has to be the disease, and that's more along the lines of Lewy body disease. The other confusing part, and so that really is the distinction. And yes, you can get diagnosed with Parkinson's disease and be misdiagnosed and have Lewy body disease, usually more so than the other way around, but both are possible. It does get confusing if the hallucinations start shortly after I put people on a little bit of medicine. That's still probably Lewy body disease, but you can't be sure. But this is why it's confusing, and this is why it's so difficult. The other kind of confusing issue is the Lewy body itself. So Lewy body is a pathology thing. So when we autopsy Parkinson's disease patients, Lewy body disease patients, and we stain their brain and we look at it under a microscope, you can see these clumps of protein in various parts of the brain. This is the clump of protein is called a Lewy body. The confusing part is that you get Lewy body pathology, i.e. Lewy body clumps in your brain in both Parkinson's disease and Lewy body disease. It just really is a matter of how much, how widespread, and where it is. So if you're looking into pathology or things that talking about, more science stuff or brain pathology, it gets really confusing when you're trying to understand what a Lewy body is and how it relates to the different types of diseases. That's a little bit more information than anybody here probably cared to know. But that's why it gets a little bit confusing. And that really is why there is a lot of misdiagnosis. Again, they're Parkinson's plus conditions for a reason. They look a lot like Parkinson's disease. It isn't until you start noticing the progression or how people respond to medicine or these other symptoms before you say, well, maybe it's not typical Parkinson's disease, maybe it is Lewy body disease, maybe it is PSP, whatever. And so again, just a little bit of insight into all the things that are going on in my head when I'm looking at a patient, listening to a patient, examining a patient, is I'm trying to tease through all these things as quickly as possible to give you the best answer that I can. How helpful are those device reports? So we're talking about the watch again. So I had a deal with a company where I could get the watch for free as long as I gave them my opinion, but then they cut me off, so I stopped doing it. How useful were those information? I mean, they were okay. What I would use them would be to say, how much downtime are you having? So there was like a range where the graph would be, and if you were down here, you were off. If you were here, you were dyskinetic. And so I could use that to some extent to guide what I was going to do from a medication standpoint. But realistically, patients are pretty good at telling me, and they correlated with exactly what the patients would tell me in terms of on off. And so it gave me more definitive or accurate information as opposed to just objective data versus subjective reporting. But realistically, I don't think it helped as much as I would hope. Father with Parkinson's is having a lot of trouble sleeping, which is causing other issues. Any recommendations for things that might help? I've read about Klonopin, Seroquel, and CBD as possible options. Thank you. Well, you're welcome. Sleep is a huge problem. So again, and I've talked about this before, going back to what I just talked about. So the diagnosis of Parkinson's disease is based on 4 motor symptoms: tremor, stiffness, slowness of movement, balance problems. That's how you get the diagnosis. But believe it or not, those are not the most important symptoms in Parkinson's disease. And we've studied this. It turns out that all the so-called non-motor symptoms of Parkinson's disease are actually more impactful for quality of life than the motor symptoms. We know this. The problem is we are not very good, or we are much less good at the non-motor symptoms than we are the stiffness and the tremors and so forth. Carbidopa levodopa works much better for tremors and stiffness than it does for sleeping problems and anxiety and depression and vision changes and bowel problems. These are the much more difficult symptoms to treat, and they are the ones that impact quality of life the most. There are some things you can do about sleep. So first and foremost is good sleep hygiene, which nobody ever does. Try not, watching TV in bed or during bed, screen time at a minimum, making sure it's dark, it's quiet, relaxation techniques before you go to bed, not a lot of exercise before you go to bed, watch how much caffeine you're drinking later in the day, all things that, you don't need me to tell you about. However, even with those things, sleep is still a major issue in my patients. And you're right, if you don't sleep very well, all of your other symptoms are worse. It depends on the sleep problem. So there are a few sleep problems that go along with Parkinson's disease. So one is restless legs. So restless legs and Parkinson's disease go hand in hand fairly frequently. Restless legs is a sensation or urge to move, or an uncomfortable feeling that's alleviated by getting up and moving that tends to keep people up at night. This is different than moving in sleep. You are awake when you experience restless leg syndrome. And if that's the case, then we use more medicines like pramipexole or Mirapex, or we use Horizons or Lyrica. If you have movements in sleep, or particularly REM behavior sleep disorder, which also goes hand in hand with Parkinson's disease very frequently, which is acting out dreams, yelling, kicking, fighting, screaming, punching your significant other, throwing yourself out of bed. Then we use medicines, or first I usually start with melatonin. Klonopin is usually the next best choice. If it really is just an insomnia, which is the inability to fall asleep, then again, we do use some Klonopin. I'll use Remeron. Again, there's a host of choices. I try to stay away from the Ambiens, the over-the-counter sleep aids, and not that they're bad drugs. It's just in my experience, I've noticed that people tend to need them. So once you start taking Ambien, or once you start taking Tylenol PM or Advil PM, and you do that for a few days in a row, you need it. You can't sleep without it. And that's been my experience. I don't know if that's everybody's experience. That's more my opinion. So I try to avoid those kind of medicines. I'll usually go to something like Klonopin or Remeron. Seroquel is not bad, particularly if you have hallucinations. Medical marijuana or CBD products are also very reasonable. So I've been a certifier of medical marijuana for I don't know how many years, whenever it was first approved. I was one of the first people to sign up to be a certifier. And my experience has been kind of iffy at best. It definitely wasn't a game changer or a cure-all like people were touting it to be, and some people still do. But it does have its role. And probably the three things that I found it the most useful have been sleep, anxiety, and pain. And then secondarily, if I get you sleeping better, or I work on your anxiety, or I work on your pain, then secondarily, tremors and stiffness and slowness tend to be better. But sleep is one of the issues where I have had some success using some of the the marijuana products. But much like everything else, it's trial and error. And so there's no good way to know which would work the best. You tend to start with ones that you think are safer. Although all of them have potential side effects, there's no such thing as a side effect-free medicine. And so you just kind of have to pick and choose the lowest amount of medicine you can try getting. I use trazodone too. So that there are a host of medicines that I'll use to try to help with sleep. But this is where, again, close communication with your neurologist, with your movement disorder specialist. If things really get bad, there are sleep specialists. So again, sleep apnea also tends to be prominent in a lot of my patients, and that's treated with a CPAP machine. And so it's not uncommon for me to also send people to a sleep specialist to have sleep testing done. So there are some things that you can do to try to figure out how to sleep better. But you're right, if you're not sleeping well, everything is worse. That's why it really is important to try to look into. Why can I play golf one day and I can hardly walk the next? Good question. I don't know. If I knew the answer to that, I'd be a millionaire. Then I would have deep understanding into how the brain works. And I don't think even the best neurologist on the planet has a deep understanding of how the brain works. In fact, I think we're wrong about a lot of the things we think. The short answer to that question is because you fluctuate, and everybody on this call fluctuates. You're going to have good days. You're going to have bad days. You're going to have in-between days. Some days you'll have part good, part bad. And my idea, or my thought behind that is it depends on so many things. It's really hard to predict. So we think that you having a good time correlates with you having enough dopamine, or the appropriate amount of dopamine on the right receptors to make that good time happen. The problem is the amount of dopamine you have at any given time is very, very variable. It's not measurable, and it's dependent on so many things. It depends on what you've eaten. It depends on how much medicine you've taken and when you took it. It depends on how active you've been. It depends on your mood. It depends on how well you slept. It depends on how active you were the day before. It depends on if you're sick with something. It depends on so many things that it's impossible to piece together, oh, when I did this, I had a good time. And when this happened, I had a bad day. It's so variable and so dependent on so many things that you can't measure or don't think about on a day-to-day basis. It's impossible to predict. But that's my short answer as to why some days you have good days and some days you don't. The best thing you can do is, again, try to pay attention. If you're able to tease out things that say, hey, every time I do this, I have a problem, don't do that. Again, yes, they pay me to say stuff like that. But at the end of the day, you just have to do your best and just know that your symptoms are going to fluctuate. You're going to have great days. You're going to have periods of time where you don't think you have Parkinson's disease at all. And then you're going to have days and times and weeks where you feel terrible. And I am not going to be able to tell you why that is in any given instance. You just have to do your best, maximize the good times, use them to your advantage, minimize the bad times, rest and do more relaxation when you're having a bad time, stay out of trouble. That's really the best you can do. But good question. Is there any evidence that DBS helps symptoms of dysautonomia? So your autonomic, and just to kind of elaborate on that a little bit, your autonomic nervous system is your part of your nervous system that controls automatic things. Things like blood pressure, heart rate, going to the bathroom, sleep. These are all control. You don't think about your heart rate going up. If you get up and walk, your heart rate goes up. When you stand up, your blood pressure goes up a little bit so you can pump blood to your brain and not down to your leg. You don't think about that. That's your autonomic nervous system in action. The problem is in Parkinson's disease, and definitely some of the Parkinson's plus conditions, that autonomic or automatic nervous system doesn't function correctly. And probably the best example of this is orthostatic hypotension, which is you stand up and you get lightheaded or you pass out. Very common in a lot of my patients. And it's because the mechanisms here, the receptors and the baroreceptors that are supposed to control that, don't work very well. So in a normal person, when they stand up, instead of all the blood pulling in their legs, their blood pressure goes up a little bit, their heart rate goes up a little bit, and you pump it up to the brain. When those receptors aren't functioning correctly, you stand up, those receptors don't kick in, all the blood goes to your legs, you get lightheaded and dizzy, and if it's bad enough, you pass out. That's an example of the autonomic nervous system. The short answer to your question is I've not had a lot of success with deep brain stimulator working for the autonomic symptoms. I don't know about the literature. I'd have to go back and see if there's been any studies specifically looking at this, or any of the studies that were done in deep brain stimulators, either in the old studies or some of the newer ones with the newer technology. Have they looked at autonomic failure, or autonomic insufficiency, or things like orthostatic hypotension in patients with DBS? And I don't know, I haven't looked recently. I'll have to go back and look and I'll let you know. But my experience has been that it's not all that effective for the autonomic symptoms. I liken deep brain stimulator to the medicines. So, for the things that the medicines work well for, DBS works well for. But for the things that the medicines don't work as well for, DBS is a little bit more iffy. And so things like tremors and stiffness and slowness of movement, those are things that we're usually pretty good at treating with medicines, and they respond fairly well to surgery. Things like walking imbalance, speech, cognition, autonomic problems, these are things that medicines are much less effective for. And in my experience, that's held true with DBS as well. But again, I'll dig a little bit deeper in for you next time. I'll see if there's been any published data on that. That's just my experience. Can AHN recruit new movement disorder specialists? Man, I wish they would. I've been suggesting that for a long time. It's not like we haven't tried. We've interviewed some. Again, a couple problems with that. So just to give you an idea about neurology in general. So I went to Temple for medical school out in Philadelphia. My class had 180 kids. Yeah, I was a kid back then. Young adult people. We had 180 people in my medical school class, and all of 3 of us went into neurology. Not that many people go into neurology. Unfortunately, we are we are a cognitive specialty. And what that means is I do a whole lot of talking and not a lot of doing. And The problem with that, it's fine for me. It's what I enjoy doing, and that's what I like to do the best. The problem is Medicare and government and insurance really like to pay you for doing and not talking. And so when you're talking about making money, or when you're talking about, again, I spent almost $400,000 to $300,000 going to medical school, as do most people when they apply and end up through medical school, all of which I'll be paying back loans until probably until I die. A lot of people want to make that money back and they want to get out of debt. And so neurology is not necessarily the best way to do that. And then you take those 3 people who went into neurology, and believe it or not, 2 of us went into movement disorders. If any of you guys go to Dr. Narkopoulos up in Erie, he was in my class at medical school. So 2 of the 3 of us that went into neurology did indeed go into movement disorders, but that's not common either. That's just a very long way to say movement disorder specialists are actually really hard to find. There's probably about 30 or so fellowships around the country for movement disorders. So there are a few that come out every year. But again, that's for the whole world. That's for the whole country, at least. And so Pittsburgh also, while I love Pittsburgh, I'm from Pittsburgh, you really have to have a tie to Pittsburgh to want to come here, right? I mean, even though we tend to win a lot of best places to live awards, not exactly a huge draw for people that don't have a tie to Pittsburgh. And so again, that's really why it's so hard to recruit people. Although, yes, we are continuing to work on that. That has not slipped my ideas. Have I had success in prescribing melatonin for sleep in Parkinson's disease? I heard on a certain Facebook page that the right dose is 1 milligram for Parkinson's. I've also heard about using for a lot of other problems in high doses, suppositories, and you cannot overdose on melatonin. Sure. So I have had some success with melatonin, and this is all my experience, my opinion. Melatonin does help with what is called REM behavior sleep disorder. So this is the acting out vivid dreams. It also helps with people who have trouble falling asleep, but my experience with that has been it's temporary. So I've had a lot of patients who say initially it works and then it stops working. And so I stop it for a while, I give it more time, then I try it again and it works again, and then it stops working. So it seems to be this kind of cycle of working and not working. I don't know if 1 milligram is the right dose. I have a lot of people that take 3 milligrams, 5 milligrams, 10 milligrams. I have some people that go as high as 12 or 20 milligrams. I don't necessarily say push it that high, but I have some people that do whatever they want. Believe it or not everybody listens to me when I give my advice. And again, I don't think you can overdose on melatonin, at least not as far as I've heard. But what I found is just that it seems to be cyclical. It helps maybe there are some people that it helps for a long time. And I've had success with melatonin. But I have a lot of people that say, initially it helps, and then I have to increase the dose, or I have to take a break, and then we go back to it. I've had better success with the REM behavior sleep disorder, but even then it's hit or miss than I have with just pure insomnia. But again, I think it's easier, maybe gentler, less prone to side effects than, say, Klonopin or Trazodone or Remeron or the other medicines that I would use. And that's why I usually start with it first. What's the best way to differentiate between MSA and Parkinson's? Well, now I have to go back to my Parkinson's plus condition talk again. So MSA is another Parkinson's plus condition, so multiple systems atrophy. The hallmark of multiple systems atrophy is significant autonomic failure. The autonomic or automatic nervous system really is impacted in multiple systems atrophy. And that usually presents as severe orthostatic hypotension, meaning those people stand up and they pass out. And a lot of times that is a very big struggle to try to work on. That's really how I differentiate between the two. If you have very severe, very early prominent orthostatic hypotension, then I really think that's probably more likely MSA than it is typical Parkinson's disease. Now, MSA comes in 2 types. MSA comes in a Parkinsonian type, it comes in a cerebellar type. And so some people present to me with a lot of balance problems or cerebellar ataxia, and they can also have multiple systems atrophy, but I'm digressing here. The short answer is it's really the autonomic insufficiency or failure. that's pretty significant and severe, more so than what I see in Parkinson's disease, and it's earlier. So the autonomic problems oftentimes in Parkinson's disease are delayed at least a few years or longer. In multiple systems atrophy, there are sometimes the very first symptoms that people have when they come to my office, and they're hard to treat. Spinal stenosis is a little bit different. So spinal stenosis, again, if let's say you have and this is, stenosis is narrowing. So if you have narrowing in your spine that's crushing your spinal cord, it can, interestingly enough, and I tell this to patients when I'm talking to them, it can give you Parkinson's symptoms. So again, one of the problems with diagnosing people with Parkinson's disease is you have those 4 cardinal features that I mentioned with no other causes, but those symptoms are not specific. If I have a bad neck, it's going to make me stiff and sometimes shake. If I have a bad back, I'm going to be slow and my balance is going to be bad. If I have arthritis everywhere, I could have all of the above. And so this is, again, where it gets a little bit tricky, and spinal stenosis is one of them. I've seen patients who were diagnosed with Parkinson's disease who then came to me, and it turns out they just had a really bad cervical spine, and they ended up needing an operation. Now, again, there are some physical exam findings that you can get. So for instance, reflexes are usually increased or changed in spinal stenosis, but really imaging is your best choice. So EMG, an electrical study, imaging of your neck, imaging of your spine. If there's any suggestion that it could be something other than typical Parkinson's disease, that's when I'll go do imaging or more testing to make sure I'm not missing something else. But again, you're right. All of these questions are great. There are a lot of things that come to my office that look like Parkinson's disease, that sound like Parkinson's disease, that smell like Parkinson's disease. I don't smell patients, don't take that wrong, that turn out to be something different. And so again, this is where a movement disorder specialist, in my opinion, is better than a general neurologist, who's better than your primary care doctor. You know, I spend my entire day examining patients with movement disorders, predominantly Parkinson's disease. And so, again, not to toot my own horn, but I think that makes my exam skills and my experience much more useful than, say, a general neurologist or a primary care doctor. But again, that's really the difference there. How does aggravation, anger, emotional upheavals affect the major symptoms? A lot. And so especially tremors and stiffness or walking problems, everybody on the call knows that if you're upset, if you're nervous, if you're anxious, if you're agitated, if you're in an emotional upheaval, your symptoms are worse. You shake more, you're stiffer, your balance is worse, your mood is worse. There is a lot of correlations between mood and a lot of these things and physical symptoms. And if you're calm, or if you're relaxed, or if you're having a good time, you'll feel better. Your physical symptoms will be better. Not that we can necessarily always use that to our advantage or figure out what to do about that, but there's definitely a correlation between all of those emotional outputs or emotional inputs and your physical symptoms. Again, if you think about dopamine, dopamine is not just in the movement pathway, right? It's in the reward pathway. It's in the emotional pathway, along with serotonin and norepinephrine, which are all very close. And not to mention, in Parkinson's disease, it's not just dopamine that's affected, even though that's what we spend the majority of our time talking about. Serotonin's affected, norepinephrine's affected. And so you do have all of these combined symptoms, and they all play a role in how you feel and how you look. And so I think I'm pretty sure everybody here has found that all of those things amplify and make your symptoms worse. Is there anything definitive for imbalance and freezing? Yep. Exercise. I feel like everybody knew where I was going to answer that question. David knew the answer to that question before I even threw it out. He was ready to jump in. The only thing that has ever really been shown to be beneficial in walking, balance, and to a less extent in freezing, is physical therapy and exercise. There are some medicines that I'll try that have a little bit of iffy data behind them. I'll use things like amantadine for balance. I'll use Exelon. Ritalin has a little bit of evidence in freezing of gait, although it's iffy. But because these are such hard problems to fix, because there really aren't definitive answers or treatments for these things, I'm willing to try just about everything if they'll work in somebody. And so, no, there really isn't a great solution for those types of problems. These are really hard problems to fix. outside of doing your best to exercise. And oftentimes I send people to physical therapy for it. Have I heard of PEMF, pulse electromagnetic field therapy, helping the brain heal? Yes, I feel like maybe you sent this to me before, or somebody brought it up, and I did watch a short video on it from the website. And electromagnetic pulse therapy is not new. So we've been doing in mainly in the mood disorder, so in depression. They'll do transcranial magnetic stimulation, direct and indirect pulse therapy. And this was actually looked at in Parkinson's disease, and it did actually help. And it was looked at specifically for walking and balance. And it did actually help, but interestingly enough, it only helped the people who also had concomitant depression, which I thought was really weird. And the data has been iffy. It's been tried to been replicated. It hasn't really shown up very much. But there is something to it. Again, if you think about what your brain is a bunch of electricity. And we can bend that somewhat to our will or to try to help or change things. Again, we know that if we stimulate it, this is what the deep brain stimulator does, that it works. We know that, different types of pulse or electromagnetic therapy does change some things, epilepsies, depression, mood, things like that. So there is some science to it. I haven't seen enough evidence behind it. I don't know how readily available it is. I feel like you have to have special technology, special training, things like that. So I don't know how widespread it is. I'd be willing to bet it's not covered by insurance, because insurance sucks and nothing's covered by insurance that is actually helpful. And so I think that it's going to have limited use to it. But I'm always open for better suggestions. I'm always open for new things. I'm probably more pro alternative therapies than most doctors are, because I recognize that I live in a world of gray. I live in a world of things that I can't specifically diagnose black and white, and I live in a world of things that I can't fix. If I had a cure, or if I had a disease modifying medication, then maybe I would be less inclined to think about things like medical marijuana, acupuncture, chiropractic therapy, pulse therapy. But I don't. And since I don't, I am always open to the idea that maybe there is something else out there that could help, whether I learned about it or was trained in it or not. And so again, the more you guys learn, the more you guys find out or hear things, send them to me. I'll give you my opinion. And the more and more they become mainstream, or the more data they collect to support their use, the more you'll see us use them. Is ataxia part of Parkinson's disease? I mean, it could be. So ataxia, and again, interestingly enough, I just gave a talk to residents and medical students at lunch about movement disorders. And what I explained to them was, I am not really that good at specific and definitive diagnoses. What I am good at is labeling what I'm seeing. The words that you'll hear us use, like tremor is not a diagnosis. Tremor is a description of a movement. Myoclonus, dystonia, hemiballismus, chorea, ataxia. These really aren't diagnoses. These are really descriptions of movement. Ataxia just means difficulty with taxiing, i.e. moving, walking and balance problems. Now, generally, we think about ataxia as a cerebellum problem. So the cerebellum is the back part of your brain that controls walking, coordinated movement, balance, things like that. And we do know that it is impacted in Parkinson's disease. It depends on to what extent. Do you have typical Parkinson's disease that also has walking and balance problems, i.e. an ataxia? Is it more of a short, shuffling, festinating gait of typical Parkinson's disease, or is it more a wide-based, staggering gait of cerebellar ataxia? I give whole lectures on walking problems. That's how complicated they are. The short answer is yes, it could be part of Parkinson's disease, but the walking and balance problem of any type in Parkinson's disease is much harder to treat and fix than the other symptoms. That is not something that responds to medicine very well. You can't see behind me, but I have a brain drawn on my whiteboard that has a whole bunch of arrows and lines through it. And the short answer is I draw that up there as I learn more and more things when I read things. And one of the things that I came on, this is not new information, is that the cerebellar pathways, or the balance pathways, are less driven by dopamine than they are by other chemicals, such as acetylcholine. And again, that doesn't necessarily help us all that much treat them better, but it does mean we use different medicines or things like that. That's a long way of saying yes, ataxia, i.e. walking imbalance problems, are part of Parkinson's disease, although they could be in addition to something else, and they're going to be hard to fix no matter what they are. I would highly recommend physical therapy, walking, and exercise. But I recommend that to everybody, so that's not new. With regard to sleep problems, how is the R? I don't know. That one I'll have to look up. I'm not, I don't know what that is. Let me write it down. I don't, beyond the medicines that I talked about, melatonin, Klonopin, Remeron, Seroquel, I also use light box therapy. I don't know if you guys are aware of light box therapy. It's exactly what it sounds like, where basically it's a bright light that you use. So that's actually a treatment of fatigue. I can't say that I've recommended it recently, but that just brought the idea that that actually has been shown to have some benefit in people who are having a lot of fatigue or sleep problems. Beyond those kind of things, I don't delve into a lot of the procedures, the devices, things like that. If we start getting into things like that, then I usually defer you or refer you to a sleep specialist to really work on that. They have much better handle or use of technology, devices, machines, things like that that'll help you sleep. I'll look into it, but at the end of the day, that's probably not something I'm going to have a lot of experience with. That's something I'm going to defer to a sleep specialist for. How to get enough physical therapy for my mom through Medicare? Man, if I knew the answer to that question, I would be able to fix it. I would be able to help everybody so much better. Pay off a governor, send a bribe to the president. I don't even know who makes the decisions for insurance companies these days, in all honesty. But that is a problem I run into all the time, where if it were up to me, the best thing, if it were up to me, every single one of my patients would have a personal trainer, a dedicated personal trainer that worked with you one-on-one, that gave you specific things to do to work on your specific problems. The second thing that I would do if I couldn't get a personal trainer is everybody would do physical therapy at least a few times a week forever. This is why they don't ask my opinion, because nobody's going to let me do that. And so the short answer is I have no idea. Write to your senators, petition the insurance companies. The long and short of it is insurance dictates everything that I do. And it dictates how much therapy you can get. It dictates which kind of imaging or studies I can order. It dictates what kind of medicines I can use. As everybody who's on this call or on this phone or video knows, if we try to get an expensive medicine for you, or if I try to get Rytary, or if I try to get a Nupro patch, or heaven forbid, I try to get Norians or Kinmobi, good luck with that. I mean, or Ambrosia. If I try to get any of these newer medicines, insurance dictates exactly what I can do. You would be surprised how much of your care is actually in my control. It is actually very little. Your insurance company dictates almost everything that I can do. That is terrible, but welcome to the current healthcare in this country. And that's not changing anytime soon. Insurance companies are not going away, regardless of what you think on global or nationalized healthcare or any other type of healthcare in the world that you can think of. Insurances still dictate what we can do. If you come up with a solution to that problem, everybody on the call would love to hear it. Stanford researchers are working on a vibratory glove, and the Q1 in the UK keeps showing. Absolutely. So there's a lot to be said about external cues, particularly with walking, balance, freezing of gait. This is why physical therapy will work on cueing, counting, a metronome, music, sound. All of these things have been shown to help people with walking imbalance and freezing of gait. And all of these devices that kind of give you a buzz on your chest or a buzz in your hand are cueing mechanisms. And so, yeah, I just can't seem to get my hands on any of them. I keep waiting for somebody to get me one, or for them to be more universally available in this country. I would be more than happy to work with all of these things, because anything that helps my patients, I am all for. And so, yes, I agree with all of that. It's just a matter of waiting. Massage and Reiki have been very helpful. Power of touch, or in Reiki's case, not touch, I guess, makes a difference. Do I suggest this? Yeah, I do. And actually, I'm not against all of those things. Massage, Reiki, chiropractor, acupuncture. I mean, I've had somebody have success with all of them. Now, it's generally temporary, much like everything else. You know, you go, It works for a bit, you feel great, and then it kind of wears off. You got to keep going. The downside is insurance doesn't cover it. And coming back to the insurance question, they don't like to pay for any of this stuff. Acupuncture is probably one of the more interesting things. So for a long time, I never had a patient come back and tell me acupuncture worked. And then all of a sudden in like 1 week, I had 4 patients or something like that come back and said, oh man, I've been doing acupuncture and I feel great. And I was like, well, I don't know what happened. But again, if you think about some of these techniques, take acupuncture, for example, I mean, it's been around for what, like 2000 years? I mean, if it didn't do anything, I'm pretty sure they would have stopped poking people with needles after 2000 years if it wasn't doing something. The hard part is, again, with all of these alternative therapies are getting studies to suggest they work. Because again, nobody's going to pay for randomized controlled gold standard studies for these things, and getting insurance to cover them. They're always expensive. They're always out of pocket, but yeah, they do help. And if you can do it, go for it. How will the new billing be introduced to end Parkinson? New bill being introduced to end I feel like I shouldn't give I feel like I always have the negative opinion. I've been told that I am pessimistic. I like to think that I am realistic, but I can see how those two things are confusing. So how do I think the new bill being introduced to end Parkinson's disease is going to help? I don't. Not more than what we're already doing. Again, it's going to funnel research dollars into what we're already doing, but I'm a little bit skeptical of the current research that's going on and getting us in that direction too. It has to be done. These are the steps that we have to go through. We need to do more research. We need more funding, and eventually we will get there. But again, I'm not a huge fan of the direction we're going at the moment. I can get you, sure, I've been connected to the Q1 gang. I've already talked to them. My physical therapist, Ian, if you're my patient to be coming to my Parkinson's disease clinic, you all know Ian. I rely on him to do all my work for me. He's the one that I try to fix everybody. He's a physical therapist. He actually had a couple meetings with the people who invented the Q1, but it kind of fell apart after that. I haven't heard anything from them recently. I haven't heard of their kind of bringing it to the United States anytime recently. So, again, I've been connected with them. It just hasn't gone anywhere. And with that, I'm about 2 minutes over. So I'm going to stop there. And Casey, I'm going to punt it back to you to tell them about Step Forward again.
Oh, thank you. Thank you for attending. Thank you, Dr. Leichliter. Step Forward is on Saturday, September 17th at the Pittsburgh Shrine Center in Cheswick. It's at a pavilion in case it rains.
It's a nice spot. I was there. It's a good area. Everybody should come down.
We'll have music.
I'm on call that weekend, so I'm going to try to make it, but we'll see how that goes. But yeah, everybody should come down. It's a good time.
Yeah, it's our peer-to-peer fundraiser. It's when we raise the money to be able to do programs like this. So please consider coming, starting a team. Boom whackers, music, vendors, movement, community, and a walk. Well, you will see you there. And before that,
I was going to say, I don't know when the next one is.
The next talk.
I'm sure it's the first Thursday of September. I don't know what date that is.
First Thursday of September, which is, let's see here. Mark your calendar.
Yes, I have a calendar right in front of me that I could look at. But Casey, I thought
it's the first. Okay, we'll see you on September 1st, if not sooner.
Again, and as long as you guys keep having questions, if the day ever comes where you guys don't have any questions, that's when we'll stop doing this. As long as you guys keep sending questions, we'll keep doing it.
Oh, and next month will be the 2-year anniversary of this program.
All the more reason to invite your friends. It'll be a party.
Absolutely.
We should serve cake too.
We'll eat it virtually. Bye, everybody. Thanks for joining us.
Oh, and can everybody say hello to Sheila Raza Self? She is a new staff member of our organization, and she's going to bring a whole new set of skills. So she's waving if you can see her on your screen there.
Hi, everyone.
She's in charge of bringing the drinks next time.
I'm excited to join everybody.
It's great to have you. Thanks.
Thank you.
Wonderful addition.
Great.
Bye, everyone.
Bye, guys. Have a good month.